So we've got Lucie Cunningham and Aoife Smith joining us now. Lucie Cunningham is the founder and CEO of the HomeShare, Ireland's leading HomeShare social enterprise. She established that in 2017. And we also have Aoife Smith. Aoife Smith is a social entrepreneur and co-founder of the Great Care Co-op. Thank you.
Hi, I'm Lucie from the HomeShare. Thank you so much to Kim for inviting me here to speak today. So, look, I'm here to talk about home sharing. Obviously, it's we've had a very clinical, very interesting and important conversation about dementia. I'm here to talk about the realities on the ground, and it's devastating when somebody does receive a diagnosis of dementia. What you do with that diagnosis as a family carer, or yourself. We all know that home care it's brilliant, and I think we're very lucky in Ireland that we do have, although it doesn't always work. Most people would have a home care package, which is fantastic, and that is enabling people to remain living at home. I think 65% is the official figure, I think, of people who say that they want to stay living at home. I think we all know that figure in reality is probably a lot higher. But home care is a bit restricted as well. I'll go into a few reasons why in a few minutes. As I said, most people want to stay at home. With home care, obviously it has to balance safety, support, quality of life, but we do have a serious problem in home care. There is no supports, there is no home care offered for nighttime. So once there's sundowning, if someone is lucky enough, they would have a carer coming in, in the evening or nighttime, maybe to help somebody, to support them getting to bed. But what happens between, say, 8 o'clock at night and 8 o'clock the next morning? That's a long time for somebody to be on their own at their most vulnerable. So what is home sharing? Home sharing, it enables unrelated people to live together for mutual benefit. It's a reciprocal arrangement. Both parties have something they need from the other person, but they also have something that they can offer. So we match very carefully younger people, although the average age of our sharers is 40, believe it or not. We match them to live with an older person or somebody who is maybe living with a disability or an intellectual disability. And probably about 40% of our householders, as we call them, would have a diagnosis of dementia. So we match them to live together for mutual benefit. So the sharers do not pay rent. So they're not an employee, they're not a carer, they're a live-in companion. So instead of offering rent, they offer 10 hours minimum a week of company help around the house. And then they commit to sleeping in the house overnight as well. So they get their free rent. They're not paying rent, so it's giving them the opportunity to save for a mortgage. I'm not even going to talk about the housing crisis here today. That is not the focus of today, but it is helping the housing crisis. And then it's obviously enabling that older person or the person living with dementia or living with a disability to remain living at home. I'll go through a few stats in a few minutes. So the average age of our householders is 85. Our oldest householder was 103. She was absolutely incredible. I remember going into her house, climbing the stairs with her, looking at the bedroom available. And then her daughter walked down ahead of her, the lady walked down next, and I was behind her because I wanted to check out her mobility, how she was managing on the stairs. And halfway down the stairs, she turned around and said, "Lucie, make sure you're holding 2 banisters." I said, "Oh my God, you're 103. But for her, she was saying to me that home sharing was brilliant because she expected at 103 to be sitting in a rocking chair in a nursing home, waiting for God to call her. But she said instead, she had purpose in her life. She was enabling a younger person like her great-grandchildren to go to college in Trinity College, to further their education. And then she had a bit of, company and a bit of purpose in her life as well. So again, that mutual benefits, coming in there. There is social connection. And we know that they say loneliness is the equivalent to smoking 15 cigarettes a day. So, you know, that it's having that social connection for the older person, or the person living with dementia. It also, so the impact on the householders is that it's obviously keeping them at home where they want to be. It's giving them peace of mind that they're not on their own, that especially in the evenings, you know, in the winter when it's dark at 4:30, they know, great, okay, you know, someone is going, I'm going to hear the key in the door at 6:00, someone's coming home. It enhances their independence. I brought some of our annual reports, so we have a lot of data in that. So if anyone wants to grab one, if you're really bored and looking for some night reading, feel free to grab a copy. But 83% of our householders told us last year that it gave them a greater sense of purpose in their life. We have 40% reduction in hospital admissions. 44% reduction in falls. So it's actually, it's helping with, our health system as well. Hopefully sending, less patients to Tala University, Sean, you're welcome. So for the impact on the family, we know that a lot of family carers are experiencing burnout, isolation, emotional and financial strain. So we hear stories all the time where somebody, their parent or their loved one is living on their own, and they might ring them up at 9 or 10 at night just to make sure they got into bed safe and sound. Nobody answered the phone. And of course, it's just panic stations. Oh God, is mum on the floor? Has dad had a fall? And if they're lucky enough to live nearby, they'll jump in the car and drive over. Whereas when they have a sharer living with them, those days are gone. They'll just ring the sharer and Sarah say, sorry, we're watching Love Island, which apparently our sharers are opening up a whole new world to 85-year-olds and Love Island and Married at First Sight and all that kind of stuff. One lady said to me, oh, she's a great cook, and you'll never guess, and this lady was about 96, you'll never guess what I ate last week for the first time. I said, I don't know. Hummus, and I loved it. So it's bringing the world into their homes as well. But then they're also offering so much wisdom, so much wisdom. One of my favourite stories is we had a match with a retired solicitor who unfortunately had a diagnosis of dementia. But as a lot of people here know, and Sean Kennelly and Sabina as well, knowing all about the brain health, your memory is pretty good in the past. So with this retired solicitor, we matched him up with a law student. Match made in heaven. So that law student came out with a first-class degree, and the householder, he was able to, instill and pass on some of his experience, some of his wisdom. It gave him purpose in his life again. He wasn't John, 85, defined by his diagnosis of dementia. He still had purpose. He was one of those 83% of people who still had purpose in his life. The impact on the healthcare system is immense. I'll be saying it again in the AV room in Leinster House in a couple of weeks, which I'm blue in the face, but anyway, I'm here to fight the good fight. It reduces, as I mentioned, it definitely delays moving into long-term care, sometimes forever. About 50% of our householders who live with dementia do not progress on to long-term care. They have enough support at home. They might have one sharer, or they might even have two sharers, so they have double the support. And if one sharer is on holiday, there's still somebody else there. I think for people living with dementia who want to remain living at home, I think the key is look at every possible support that is available out there, and just avail of as much support as possible, to tick all those boxes, to have as much, and whether it's going to a day centre during the day, if maybe having a carer coming in 3 times a day isn't enough. Some people are lucky enough maybe to have a bit of extra money that they could pay privately, but certainly the night time is the big thing. We do have 2 reasons why home sharing may not work, unfortunately, or may not be the best the best support for somebody living with dementia, and that is if somebody unfortunately does have the risk of wandering. And that's why I was really interested in hearing the inspector from An Garda Síochána talking about the Herbert protocol. If somebody does have a risk of wandering, unfortunately, that would be a reason why home sharing may not work, because the sharer typically is in bed asleep. They're obviously there in case of an emergency. That's why they're there. But they may not hear the front door, being quietly opened and closed. The other reason is, unfortunately, if somebody is confusing day and night, again, that's another. They might be up during the night and let's go off to work, which can happen. Again, that's a reason why maybe home care or home share may not be the right support, because because they're not paid. That's why it's so financially it's viable for so many people. They're not paid because they're going out to work the next day. So they're just the two reasons why somebody may not, or hope sharing may not be the right support for somebody. Quickly go through the annual report results. 100% of our householders feel a sense of purpose and fulfillment. I think that's just incredible, 100%. 94% of householders feel more secure at home with having a sharer living with them. 82% reported an improvement in their quality of life. I was wrong earlier. It's 50% reduction in falls, 41% reduction in hospital admissions, and 53% of sharers provided assistance in an emergency. What would have happened to that person if they were on their own? That is potentially somebody on the floor all night long. They will be found the next morning, if they're lucky, by a carer or a family member. At that stage, they're probably on the floor all night long. They're in hospital straight away. Potentially, could develop pneumonia, and then, they might be in hospital for a month. They're going from the bed to the chair. They're not mobilising. Suddenly they walked into hospital, or maybe they came in on a stretcher, but they were walking until they were in hospital for 4 weeks without walking, and suddenly their only option is to go to long-term care. So it's prevention is the key. Home sharing is the only support that I'm aware of, apart from emergency services, that it is not affected by emergencies. COVID-19 comes to mind. The beast from the east, do you remember that? When there is like COVID-19, when we were all told to stay at home, over 70s had to cocoon, people were working from home. Beast from the east, or if there's any big storm, a lot of home care providers have to, rightfully so, they have to prioritise who their carers visit. Whereas our sharers are there all the time, in the evening and at night time. So it doesn't matter that if a carer isn't coming in, it's okay, I'll give Mary her meds tonight. Or it's okay that the carer can't come in at all because, Mary isn't, high risk enough that we have to cancel her calls for the moment. That's okay, the sharer has to go to the shop for themselves anyway. So look, I'm just going to finish up really with just, a couple of things. We must invest in prevention, not just respond in a crisis. I think that's really key. And the dementia may change memory, but it does not diminish the human need for companionship, dignity, and home. I did forget to put up the information, which is very silly of me. So if anyone wants to contact us, it's very easy. Our website is www.thehomeshare.ie or info@thehomeshare.ie. Thank you so much.
Thank you very much, Lucie, for a really great presentation there. And the HomeShare is just another example of, social innovations to kind of tackle key critical social issues. So the Great Care Co-op is also a social enterprise, and we are Ireland's first care workers cooperative. So it's democratic ownership. And I'm here to talk a little bit about this model in terms of how a democratic ownership model in home care that's come from a rights and equality base can impact community connection and outcomes for people using the service, as well as improving the welfare and employment conditions of those who work in the company too. Before we kind of go and look at it, I suppose it's important to look at that question, like in home care, whose needs are being served and how might home care support people to flourish. So the background to the Great Care Co-op, the why, start with why, I suppose, is really important. My background is in community development for 15 years, working with migrant women in the Migrant Rights Centre, so migrants who've been on the verge of exploitation in care work and domestic work. And we did a piece of research with the Irish Human Rights and Equality Commission back in 2015, and we partnered up with SIPTU, the healthcare division, because they have the greatest number of healthcare representatives, or sorry, home care representatives in the public sector. And we also partnered with Family Carers Ireland. And we were looking at what would home care guidelines look like from a human rights and equality perspective that took into account the rights of all the tripartite, if you like, involved in care. So the person using the services, the family carers at home who were supporting and doing a lot of the bulk of care, and then formal care workers as well. Because often we had advocacy groups that were each advocating for one of those stakeholders, but very little around bringing them together to look at a rights-based approach for all. So that was a year-long piece of research, action-based and peer-led, and we consulted over 200 care workers, both migrants, Irish, working for the HSE, working for private bodies and working for not-for-profit bodies, and directly employed as live-ins in the private home as well. And the research findings basically showed that in order to have a home care sector based from a human rights and equality perspective, that we needed to reimagine how home care was being delivered, and that the current status quo was not meeting the needs of older people and people using the services, it wasn't meeting the needs of care workers, and it wasn't meeting the needs of family carers either. So that was where the idea to set up a social enterprise and to reimagine what it might look like if we were to empower frontline care workers to have more of a say in how care should be delivered. So this was the question we wanted to ask. What would it look like? What if care workers owned the business? What if they were co-creating, and if the system enabled them to co-create care and care services with the people that they worked with? And what if it moved from being a task-based sector to being focused on relationships, because it's a universal human need that we all need warm relationships to flourish. So with the overly task-focused, it could feel like a checklist rather than actually focusing on hours more than outcomes for people. So as I say, in the Migrant Rights Centre, I worked with a group of about 500 migrant women who were majority carers and domestic workers. And they were a grassroots movement campaigning for rights and visibility, for respect and improved policy changes to recognise care and domestic work as dignified work. But despite winning lots of campaigns and policy, there was a gap between policy and practice, and on the ground, terms and conditions of employment were still not improving. And there was a recognition that you can't have great care if you don't have great jobs, that the two are intrinsically linked. How can care workers be empowered to take care of people that they're working with if their own welfare is not being considered by the organisations that they work for and by the structures in place? So the idea came to set up a workers' cooperative, a group of 9 migrant women with decades of experience, decades of building relationships with their clients and the people that they worked with, that they knew what great care looked like, and they also knew what great jobs looked like. So, coming from the human rights and equality background, you know, that this was looking at it, that it would underpin, they would be champions of equality for the people that they worked with as well. So we didn't want to just replicate another model and be a task-focused company. We wanted to flip it. So we looked externally, and there was a couple of kind of key models that we really liked outside of Ireland. In America, there was the Cooperative Homecare Associates. It was a 2,000-strong worker cooperative set up by Latino American and African American women in the Bronx, and that was doing really great work. But again, a little bit task-orientated. So Buurtzorg, some of you may be familiar with, it means neighbourhood care. It's a Dutch model set up by nurses back in the 90s. It has scaled rapidly. They're really focused on localised small team approach to delivering human-centred care in the community. Now, it's nurse-led, but research from Buurtzorg showed that one, it was up to 40% more financially sustainable for the public, for the departments to work in this way. And the second bit was that they consistently scored higher than average on satisfaction rates. So we modelled this in Ireland with carers. And what we have found is, so research was done on our model last year and published, that the worker empowerment side of it had direct benefit and improved outcomes for the people we worked in. In terms of the workers owning the company, they were more deeply invested in the outcomes of their clients, deeply invested in the quality of the service. They had a say in how care was being delivered through being brought from being isolated workers in private homes to being a collective community with regular team meetings discussing the welfare of the people that they worked with, peer learning on an ongoing basis. If you think of normal home care, care workers are going into isolated homes and they're working alone. They're not learning from peers like they might be doing in a hospital setting or a nursing home setting. And often they don't meet with their colleagues either. You are a lone worker and you never meet your colleagues at all. So this model was challenging that and bringing people together. So how we work is in teams of 6 to 12 carers in a particular area of about 10,000 people, with about 15 to 25 clients working with that team of 6 to 12. So it's hyper-localised. The carers live in the area, so they get to know the networks. They do community outreach to find out what are the services through local community groups, through the HSE, through voluntary groups that are in the area, and they refer in and refer out. So we know that isolation, poor health are very connected. So one of the things that the co-op focuses is when we go in at the start, we will do a full assessment, a holistic assessment to map what are that person's needs and what do they need to age well. The individual is at the centre. We map who their friends and their family are, their neighbours, which are the natural informal supports that all of us have, and then also map the more formal care supports around them, such as their care teams, GPs, public health nurses. And the carers are empowered and permitted to work with the individuals and link in with those other actors in their circles, which is very different because normally in home care everything goes through your supervisor. So you might have an issue where you're trying to advocate for somebody, but you don't get any results. So just one thing that came up when somebody was speaking earlier on. So just 2 weeks ago, we had the issue where a carer was going in to her client and she was able to see, because she goes in all the time, that there was a change in the smell of the urine. So they were able to have a conversation then about maybe should we take a urine sample and bring it down to the GP. So they did. They rang the GP, took the urine sample down. She had a UTI. So then they were able to go get that delivered to the pharmacy. And by the evening call, the person had their antibiotic. And, that's a potential, as you were saying, because often you would get people are dehydrating when they have the UTIs and they're not picked up, and we see it all the time. But these are the kind of day-to-day positive impacts. If you've got different carers going in all the time, there's no consistency, particularly supporting people who are vulnerable to live at home. We have to have the consistency so that they can see the baseline and then be able to use that to advocate. But if we don't have the structures that are in place to allow that, then we will continue to just get, poor results and outcomes for people using home care services. I'd just like to show a little video now, just before we finish up.
The way we do things is we like to make sure that people get the care that they want, not just the care that they need.
It's completely client-centred. We do things the way the clients like things done.
The co-op recognises the value of carers.
We keep people connected to their community.
And we have a voice as a team member.
A group of us had been campaigning for over 10 years, came together to set up what is today the Great Care Co-op.
I had experienced the difficulties and the challenges of being a migrant worker, of having low wages, bad working conditions, problems that arise with our immigration status.
We have many women from different countries, and I think that for me also was one of the main reasons I chose to join to the Great Care Co-op, because I saw they will support immigrant women as me. And we have many women from different countries.
We're just frustrated by seeing people either being exploited, not being paid well, not being valued as care workers, and we felt that there had to be an answer somewhere. So for people to be able to have better working conditions, for ourselves to be paid better, to create better employment for ourselves.
We value the carers and the client, so it's all about ensuring that both the client and the carer thrives, because we see this as being a win-win situation. Happy carers, happy clients.
Having proper acknowledgement of what we do and being seen and working together makes a huge difference, because it's a sort of undervalued role that a lot of people don't realise how much it takes out of a person. So having a team that you can sit around and talk about the good things and the bad things makes a massive difference.
Other home care providers, you generally don't have contact with your colleagues, but we are very much a team together, and we're stronger together.
When we start with the client, we will map the person's needs emotionally, socially and holistically to get a really good picture of what that person's needs are. Then we also work and we map out who are the key people in their lives, both in terms of family and friends and supports in the community that help those people to do what they like to do.
We co-create the care plans with our clients, so therefore we get a much more in-depth view of what they need, why they need it, and how to help them better.
When I began getting the ladies in the co-op over here, I was so impressed with their kindness and their professionalism and the rapport they quickly established with Sarah. That was the important thing to me, that Sarah would be happy with any carer or carers coming in. And after a week or two, I felt as they were part of my family. The carers we've had from the Great Care Co-op, they're all well trained, they're all committed to their work, they're all kind, they're clever, they know what to do, and they're really helpful.
So it's so different to the nursing home environment, because you have the time to spend with each individual client, and that's what the co-op offers as well as a carer, that you can choose the clients that you want to work with and choose the times that you can that will suit yourself and the client. You are able to take the time with the client to get to know them and their families, which is really important. You really become sort of a support for them, particularly people who are living on their own, and you become their friend as well as their carer, so it makes a huge difference, absolutely.
Carers have a voice in the Great Care Co-op, from how things are run in the organisation, scheduling, the strategic focus overall, that carers can be on the board and be part of their business owners, and that when they are out there, it's not only about delivering that shift of care for that hour and going away. It's really about thinking that this is our business.
We are gathering evidence on this, and we're very open to we've got 4 teams going at the moment in South Dublin, and we're looking to scale that out. We have a HSE contract in the IHA Dublin and South East area, but we know we need more evidence to kind of back this up. It's very new, but it's definitely working on the ground. So our website is www.tgcc.ie, or the Great Care Co-op. So, if you're interested in learning more about it, please do get in touch, and thank you very much for listening.